And yeah, a very warm welcome, everyone, from myself and my colleagues, uh, Professor Suzanne Bench and from Tina Nicholson. It's really good that you can all join us this afternoon. As you know, I think this is our ninth debate, actually, and it's part of the, as Neil said earlier, and I'll try to repeat, the Integrated Clinical Academic Postdoctoral Bridging Scheme group, um, which we've been running for the past 5 years at LSBU in collaboration with King's College London. So it's really good that you're joining us today. I hope you enjoy the debate. I'm not going to tell you what the debate is. I'm going to pass that on to Jill, who's going to be our moderator or chair for the day. And so without any further ado, I'll hand you over to Jill.
Thanks very much, Ben, and I extend my welcome to everybody as well, and I thank Neil and Ben for saying the context in which we're here today, so I don't need to repeat all of those long acronyms, etc. So we are here today to debate the topic of prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice. We will, as Neil said, have a poll at the beginning and the end of the debate and be able to see how persuasive our debate team have been today on either side of the motion. So on the team today are myself, so I'm Jill Massey, and I'll be acting as chair during today's debate. I'm a clinical specialist occupational therapist at the Evelina London Children's Hospital and clinical consultant with Cerebral Palsy Alliance in Sydney, Australia. I lead an evidence-based rehab service at the Evelina for children with and young people with hemiplegia, along with kind of neonatal and childhood stroke services. And my research areas encompass co-design methods and knowledge translation in childhood disability. It's a great pleasure to introduce two incredible colleagues to you today who present the for and against side of the debate. For the motion, prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice, is my colleague Nilou Nourishad. Dr. Nilou Nourishad is a consultant pharmacist in adult mental health and the director of the pharmacy education programme at West London NHS Trust. She leads a psychopharmacology clinic within the mental health integrated network teams and contributes to the care of patients in higher secure settings at Broadmoor Hospital. In parallel, Nilou oversees research projects aimed at enhancing health literacy and optimising pharmacological treatment in the context of mental health disorders. On the other side of the debate today, and putting forward the case against the motion, Dr. Eunice Jeffs is my colleague, who is an advanced nurse practitioner at St Thomas's Hospital in London. Eunice project manages the prospective epidermolysis bullosa longitudinal evaluation study, known as PEBBLES, P-E-B-L-E-S, which captures the natural history of adults and children with this rare disease. However, her extensive clinical experiences in the field of cancer and non-cancer related lymphedema and her PhD addressed the feasibility of conducting a randomized controlled trial of treatment effectiveness for women with breast cancer related lymphedema. Each side will have 10 minutes to present their case for and against the motion. And as Neil has said throughout the debate, please place your questions in the Q&A box to contribute and engage in the debate. So without further ado, we'll get on with the first start of the poll. Please vote for or against our motion that prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice.
Those are coming through. We'll give it just another moment. We're nearly there. Just give it another second for you all. There you go, we'll call it there. Thank you so much.
Thank you, everybody, and thank you, Neil. We will share that obviously at the end. But for now, let's move on to our introduction of Nilou and hand over to her to present for the motion prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice. Thank you, Nilou.
Good afternoon, everyone. Over the next 10 minutes or so, I hope to persuade you that supporting clinical academic career development should be a priority within healthcare systems, not only because of its importance to professional growth, but also because of the tangible benefits it brings to patient care. For the purpose of this debate, I've focused on 5 key factors, which are strongly related to the existence of academic clinicians within clinical settings, each underpinned by a series of mechanisms that explain their impact. First, a stronger evidence-based practice. Evidence-based practice is more than using findings for research. It actually helps to reduce variation in care, improves the effectiveness of intervention, and that's how it influences patient outcomes. It identifies what works best, for whom, and what conditions, and therefore minimizing ineffective or harmful interventions. Evidence-based practice. We are in slide 3 now, I think. Evidence-based practice is dynamic. Clinical research keeps care current by continuously testing and updating what is considered best practice. Without research, clinicians would rely on outdated knowledge or anecdotal evidence. Clinical research identifies subgroups, those people who don't respond to treatment the same as the rest of population. We all know about treatment resistance, schizophrenia, diabetes, and other conditions. They provide with precision of care, for example, based on gene therapy, metabolic information, all of which are coming through research. An example of that are breakthrough through pharmacogenetics. Research doesn't just find the best treatment. It also explores how to implement it effectively in real-world setting. Research encourages routine data collection and outcome tracking, helping teams audit their performances and refine interventions. This creates a cycle of continuous improvement rooted in real-life practice and real-life evidence. Another factor strongly associated with the existence of academic clinicians within clinical setting is enhanced patient care. The studies have shown that hospitals with high research activity had significantly lower mortality rates and shorter hospital stays. In the NHS, research has shown that hospitals, the research active NHS hospitals, had a 5% lower mortality rate for emergency admissions. Academic clinicians stay current with the latest diagnostic and technologies, reducing delays and errors. An example of that is cancer care. And academic oncologists are more likely to follow updated staging and testing protocols, leading to earlier and more accurate diagnosis, improving survival. Clinical research supports better and more personalized healthcare decisions, improved clinical outcomes. It supports elimination of wasteful care and wasteful expenditure simply by comparing choices for prevention, diagnosis, or treatment. Patients, on the other hand, who are under the care of academic clinicians are more likely to receive new effective treatments earlier, including, genetic testing, genetic modifications, biologic treatments, and so on. Academic clinicians are more likely to follow NICE guidelines, for example, or evidence-based protocol, and this reduces complications and readmission rates. They are trained in research communication, enabling them to explain treatment options using up-to-date evidence-based information, improving patient understanding about their own condition, the need for treatment. By doing so, they enhancing adherence to treatment. This leads to higher patient satisfaction and more personalized care plan. Academic clinicians often implement structured follow-up systems tied to research protocols or audits, leading to early identification of treatment failure and side effects. Another factor associated with the existence of academic clinics is increased innovation and quality improvement. In fostering a culture of innovation and quality improvement, academic clinicians can identify areas of improvement and development and develop solutions to address challenges, leading to more efficient and effective healthcare. Research enables innovation by identifying insufficiencies, safety risks, or poor outcomes. Research, especially implementation science and clinical audits, provide the data and framework for almost every single quality improvement projects. Clinical research method also allows safe and rigorous testing for new models of care, digital tools, for example, treatment pathways before scaling. This actually reduces harm. Research underpins quality improvement by providing robust data to support investment and service redesign, ensuring changes are evidence-based, not anecdotal. In summary, research fuels innovation and quality improvement by systematically identifying problems, generating and testing solutions, and embedding change based on evidence, leading to safer, more effective, and more responsive patient care. Improved staff retention and recruitment is another factor that is strongly associated with having academic clinical clinicians in workplace and having research-oriented organizations within healthcare system. Research activities can make departments more attractive to potential and current staff, contributing to better recruitment and retention rates. Clinicians are drawn to environments that support academic development, innovation, and career progression. Research active institutions are viewed as prestigious, dynamic workplaces, making them more attractive to top candidates. Clinicians who are engaged in research report higher job satisfaction due to intellectual stimulation, autonomy, and development opportunities. Evidence from a recent survey conducted by GMC report that those clinicians, the clinicians that involved in teaching and research, reported lower emotional exhaustion and greater commitment to their organizations. Research opportunities create alternative and hybrid roles, helping to retain staff who might otherwise leave clinical practice. Academic clinicians serve as vital translators of evidence, ensuring that cutting-edge research findings are understood and applied in everyday clinical setting. They disseminate knowledge through teaching, mentoring, and supervision, promoting evidence-based thinking amongst students and trainees and colleagues. Each academic clinician can upskill hundreds of others, directly improving patient care quality. Academic clinicians often lead or contribute to national and local guideline development, ensuring that evidence is rigorously interpreted and applied. For example, NICE guideline panels often include clinical academics who balance data interpretation with clinical realities. They disseminate innovation and insight through peer-reviewed journals. Shared learning avoids duplication, spreads effective interventions faster, and improves and informs policy making. Through academic roles, they help build communities of practice, journal clubs, research collaboratives, online learning hubs that continuously exchange and evolve knowledge. Academic clinicians often co-produce resources with service users and disseminate findings beyond academia, enhancing patient health literacy and shape decision-making. In summary, academic clinicians are key knowledge brokers. They not only generate evidence base, but also ensure it reaches the bedside through education, guidelines, collaboration, and system-wide dissemination. I thank you all for the time you gave me to put my arguments to you. Thank you.
Thank you very much, Nilou, and thank you for holding to time. That's great. I look forward now to hearing some of your comments in the chat box, and obviously putting your questions as we go through in the QA box for us to answer at a little later on. But without further delay, I'd like to introduce Dr. Eunice Jeffs to put forward the case for the against the motion, prioritising clinical academic career development within healthcare systems would not enhance patient care and strengthen evidence-based practice, is the case that Eunice will be putting forward. Thank you, Eunice. I hand over to you.
Thank you, Jill. Can people hear me? Okay, I'm very sorry. I've got a poor voice. So thank you for the opportunity to argue against this motion. My job is to provoke and challenge your thinking about this topic, which you may think is a very good idea, particularly as this is a postdoc bridging scheme debate between practitioners exploring development of clinical academic careers. However, I'd like to consider some of the consequences of prioritising clinical academic career development within our hospital and community healthcare systems, and to challenge the assumption that this focus would enhance patient care and strengthen evidence-based practice. Next slide. Oh, that's fine. That slide's good, thank you. Inevitably, prioritising one group over another would create winners and losers. At best, new money would be found to invest in clinical academics without removing investment from other groups. But most likely, if clinical academics receive a bigger piece of the pie, it would be at the expense of training budgets or posts for other practitioner groups. So there could be less money available for training and development of the rest of the workforce, including ward staff and community carers and other specialist groups. Next slide. You may be aware that from January 2026, level 7 apprenticeships, master's level equivalent, will no longer be available to anyone over age 21. Because the government is prioritising apprenticeships to those aged 21 and younger, hospitals will not be reimbursed for post-registration level 7 training, and this will particularly impact career development for those remaining in clinical practice. The change probably won't affect the development of clinical academics, as there are other funding opportunities for them, but it will have a detrimental effect on the funding of leadership training and those working to progress their careers as specialist or advanced practitioners. And this at a time when we will need a skilled workforce and investment in leadership and change management, development of expertise and upskilling of existing and new staff, so that they can pivot to achieve the new approaches to care within the NHS 10-year plan, as we are to move from hospital to community care and from a focus on treatment to that of preventative health. Next slide. The NHR and other schemes already exist for the advancement of clinical academics, providing access to funding opportunities not available to those practitioners who do not wish to pursue academic development. Over the past decade and more, the NHR have expanded the offering of awards to develop clinical academics, now offering pre-doctoral awards through to senior research awards and professorships. with additional training and development awards. Next slide. In contrast, other groups such as clinical nurse specialists, I think we need to move on one, please. Other groups such as, thank you. No, back one. Oh, yeah, sorry, I'm looking at the wrong slide. In contrast, other groups such as clinical nurse specialists and AHP specialist practitioners are limited to CPD funding and any other bursaries or charitable funding they can find. Therefore, as clinical access, academics can access NIHR funding and also access local CPD funding, it would not be appropriate to expect employers to prioritise further local funding for the development of clinical academic careers. Next slide. Prioritising the development of clinical academics without equal consideration of investment into those groups who will help deliver research and implement findings will result in failure to launch research and its findings. This can be an expensive exercise, and I've outlined here 2 cautionary tales. My background, as Jill said, is working with individuals with lymphedema, chronic limb swelling, whether as a side effect of cancer treatment or due to other cause. I wanted to improve the initial treatment offered to individuals newly presenting with limb swelling, as the UK is offering only self-treatment with hosiery and not the internationally recommended 2 to 3 week course of intensive practitioner-delivered treatment prior to self-treatment. So my PhD was to test the feasibility of conducting a future definitive trial of treatment effectiveness for women newly presenting with breast cancer-related arm lymphedema, comparing a 2-week daily practitioner-delivered treatment programme with usual UK care. However, when the time came to begin site setup, the practitioners reported lack of treatment capacity to deliver the study intervention, even with full reimbursement of costs, due to insufficient number of trained practitioners. Further, these practitioners and others I recruited to the study could not envisage ever being able to implement any future findings which supported providing practitioner-delivered treatment plus self-treatment instead of self-treatment alone. They lacked the resources and capacity. A second example is from a colleague who was part of a group exploring the feasibility of using a simple tool to support improvements in dementia care and care homes. They also concluded that the definitive trial could not be conducted due to a lack of adequately trained workers, in this case carers and support workers in the care homes. Here too, the researchers concluded that effective implementation of any future study findings was unlikely, and so the trial will not go forward. I estimate there was an investment of around £500,000 between these 2 studies, run by clinical academics, but without any improvement in patient care or strengthening of evidence-based practice. Building capacity for research and to increase the likelihood of implementing research findings to strengthen evidence-based practice requires investment in all levels of practitioners, not just to focus on development of clinical academic careers. Next slide, please. Which brings me nicely to question the evidence for how effective clinical academics are at improving clinical patient outcomes. Reports and blogs from the Clinical Academic Roles and Career Pathways Implement Network, CARIN, and the Council of Deans suggest that most clinical academic post holders have focused on capacity building initiatives, such as supporting others to engage in research and formal research training, which Nilou has already mentioned, and in developing research infrastructure rather than being clinically focused or conducting research to improve patient care. So I'd like to compare the evidence I found for the effectiveness of clinical academics to improve patient outcomes with another group, clinical nurse specialists, although this could equally be allied healthcare professional specialist practitioners. PubMed search for the terms effective and clinical academic in the title, which is a crude search, I admit, generated only 4 papers published in the past 10 years. And these focused on the benefit of building partnership between clinical practice and academia. For example, Newington et al. In 2021 reported findings of interviews with healthcare managers and research active healthcare professionals, which noted that associations between research activity and patient outcomes might be difficult to identify. There were other findings, but those are the ones pertinent here. In contrast, the same 10-year search for the terms effective and clinical nurse specialist, or CNS, in the title generated 69 papers, including 7 systematic review of findings. These studies and reviews concluded that the CNS role can improve patient outcomes. For example, Bryant, Rukosius, et al. 2015 reported that CNS transitional care reduces hospital lengths of stay and readmission rates and costs, albeit with low quality evidence at that time. Salamanca-Balin et al. 2018 reviewed the cost effectiveness of CNS-led interventions in palliative care and drew similar conclusions regarding reduction in stay rates and costs, although again reported mixed evidence regarding cost effectiveness. Other reported benefits from the CNS role, which were considered hugely impactful for patients' care, but challenging to quantify, included improved patient satisfaction, increased patient knowledge and adherence to recommended treatment. And I point you here to the systematic review by Lanphier and Harding published earlier this year of qualitative data for CNS supporting self-management of patients with cancer. Next slide, please. Clinical academics are not the only healthcare professional group that can model a curious mindset. To question how care can be changed to better deliver better patient outcomes. In fact, the dual role with academic responsibilities could in fact distract from clinical care. Transformational change in healthcare requires leadership by frontline clinicians, which I acknowledge will include clinical academics. Also, clinical specialist expert practitioners who will drive innovation, quality improvement initiatives, and spearhead evidence-based improvements in clinical care. We need to ensure training and upskilling of practitioners moving into these clinical leadership roles, many of whom, despite having curious minds which they apply to improving patient care, do not consider themselves to be academically minded and would never apply for clinical academic career development. Yes, we need clinical academics, but not at the expense of other key workforce groups. Next slide. So in conclusion, my main concern is that prioritising clinical academic career development within our healthcare system would have unintended consequences that would disadvantage other workforce groups and would affect the delivery of good patient care and implementation of evidence-based practice. There are already additional funding opportunities available for clinical academics, which gives them an advantage over other senior and specialist roles. For healthcare providers to prioritise clinical academic career development, this would require additional resources that would have to come from somewhere else, which would disadvantage those other groups and adversely affect patient outcomes. So my vote would be to invest in other clinical specialist and expert roles that are already demonstrating a level of effectiveness in improving patient care. Why risk destabilising an existing expert clinical workforce where there is documented benefit, such as nurse and AHP specialist practitioners? It would be much more sensible to prioritise, to invest in their career development, to support their efforts to innovate in clinical practice, to educate and provide leadership, and to undertake quality improvement initiatives. Thank you for your attention.
You're just on mute there, Jill.
Sorry. Thank you very much, Eunice. Apologies for that. I was on mute still. For a compelling motion against our statement today and our debate. So we're now moving into our time for questions. And I hope that many of you have been placing your questions in the Q&A box for us to pose to the panel and have continue our lively debate on both sides of the motion.
So we've got a couple of comments that have come through. So Christine says some thought-provoking counter arguments. And we have, let's jump in with this question because this is fresh from what Eunice was just saying. So can CNSs not also be clinical academics as part of their 4 pillars of practice? And that one was for Eunice.
I took the definition of clinical academic as a dual role employed by a clinician provider and also by an academic provider. And in that sense, I would say clinical nurse specialists are always employed by the main healthcare provider. And so, yes, it is part of their role. And that would certainly be one of the challenges to a lot of what Nilou said, that comments could be equally applied to clinical nurse specialists and other advanced practitioner groups. But if the definition of a clinical academic is that it is a role that is jointly funded or joint position between 2 or different organisations, healthcare and academics, clinical nurse specialists, I don't think, are funded that way. At least my role was never funded.
Nilou, feel free to jump in. I'm going to fire some other questions over. So Donna says, identifying academic outputs by profession is challenging. We see this consistently in occupational therapy. I personally haven't published anything with clinical academic in the title, but my CA knowledge and skills drove the work. Does Eunice have advice for how we might overcome this so the impact is identifiable?
I personally think it is very challenging. So my career development was as a clinical nurse specialist, driving lots of quality improvement initiatives, new service development, and doing some degree of evaluation, but lacking the academic side of things. And that research component I brought in through masters, but as a clinical nurse specialist. And I think the risk that I'm proposing is that by assuming the developments and the progression comes through the clinical academic role, it detracts from the research component within the clinical nurse specialist role, whether that be through evaluation or through more formal research. I don't believe that a clinical nurse specialist cannot have an academic focus and drive for the way in which they work. Not all of my colleagues within lymphedema do. Many of them consider themselves to be not at all academically minded and struggle with the academic work. So to assume that I have to let that bit go because I'm a clinical specialist and focus on clinical practice and a clinical academic focus on combining the academic with the clinical, to me, is a bit of a false argument. I'm not sure whether that fully answers the question. The person who asked, feel free to come back to me if you feel I've let you short.
Nilou, would you like to come in on that as well?
I just wanted to ask, those senior nurses in your field, obviously they are practicing at a very advanced level. Where do they get the current information from? In my view, it's because of people like you exist within the system who just, constantly updating their knowledge. Otherwise, their knowledge would be outdated. So it's people like you who, yes, from time to time might be distracted from the core clinical work to go and find current information that feed back to the clinical practice. Am I assuming that wrong?
All of my academic work, as you would call it, was done as a clinical nurse specialist prior to my PhD. So all of the evidence that I provided for my field over the last 30 years, bar the bit that's been done through my PhD, was all through funding as a clinical nurse specialist. Yes. I had a curious mindset. Unbeknownst to me, took a more academic approach than most of my colleagues, but I was not in a clinical academic role. I was not dual funded. I did not have those advantages. They were all coming out of the curiosity I had to improve clinical care as a clinical nurse specialist. And my fear is that we risk losing that.
Yeah, and I think that is a problem, isn't it? That the system doesn't allow a funding, a space for people like you to sort of, juggle between the clinical, to have them, to allow them some time to actually, do the research. But like you said, it's the same as me. I had a curious mind. I knew that, reading a BNF to patients is not going to change anything. Something else needed to change. And that led to, going research in healthcare, health psychology and psychotherapy, interventions and so on. So yes, and wasn't funded, wasn't even, any space for it. But through research kept me going. You see, like one of the things that we spoke about, I ended up in an organization that was research oriented. Otherwise, perhaps I would have left pharmacy as an ordinary practice. I only hold on to a job because I had a mortgage to pay, to be honest, and bills to pay. But I was frustrated. Research rescued me and rescued my career. So that is the bit that I'm, you know, it might not be academic. Some people think that through publication or really even completing a PhD makes them academic. You know, being involved in research doesn't necessarily mean that you have to have a PhD. You can be involved in research through other means.
So I think thank you both of you for putting forward your views on that question. I just come in as the occupational therapist on the call to Donna, and just sort of say that I think many of us, irrespective of our background, find that actually, you know, we have the 4 pillars of practice, and it's we do need to be practicing across those. And research is one of those that I think at every level needs to be embedded in our practice. But I think some of this comes down to titles and kind of who and what your actual job title is, and then the funding that goes with that. And I think Eunice, sorry, has put forward quite a case around the fact that in this case, she's proposing that a clinical academic as the job title is that it's a joint funded post. But that doesn't negate, by the sounds of things, that actually if you are funded by health, that you embed research in your practice as well. So, and I think that would be across disciplines as well. So thank you both of you very much for your views on that. Neil, was there another question we had?
Yeah,
Unless anybody else had comments to come in on that.
There's a couple of common consensuses around, you know, Jane asked, why do we have to trade one off for the other? You know, nurse,
Yeah.
clinical, academic, why can't it be both? And that was echoed by Christine in the chat box. You know, do all Greek speakers agreed it's a shame that we have to have an either or situation. Jenny's just put, adding to the question above, my question is there another way possible to the either or situation? And if so, how do we get there? What could that career pathway look like?
Eunice, would you like to put your hand up? Would you like to come in on that first?
I think this very much fits with some of my concluding statements, that I believe that there needs to be a strategic approach that takes into account the fact that to develop clinical practice, to drive innovation, it needs all of the practitioner types involved. Those that are more focused on clinical side expertise, those who have more of an academic mindset, but to bring together that knowledge and experience to ensure that, as Nilou pointed out, that there is this moving through of knowledge and expertise into clinical practice, but also that coming back the other way, the knowledge, the questions, the issues that need addressing are fed back to those who are more academically minded and are focused on research. The assumption that it's all responsibility has to be allocated to one group or another, I think, is a false premise and won't help us within the healthcare system. But my concern is that if we prioritise one group over another, we run the risk that we lose skills, we lose the ability to collaborate with these other groups, and we are weaker as a result, not stronger.
Thank you, Nilou. It looks like you'd like to come back on that.
I totally agree with Eunice, but I really also noticed that you know, one of the question is there a way around it? I truly believe, you know, that research should be embedded within clinical practice from the junior state all the way. We have to be research oriented all the time, not a, you know, like I said, not a proper academic, but just be involved in some research project that going. Our organization as a healthcare system should be actually research oriented all the time, and knowledge, you know, that evolves around that research. I just think that if from university onward, and I always said that in my own profession as pharmacy, they should be research oriented. When they you know, graduate, they should be looking for gaps and cracks within the system and pick up little research projects to find out how they can actually breach the gap. So, you know, we have our profession, our healthcare system is heavily involved in audits. So what keeps us from research? We audit all the time. Why can't do research into solutions?
Eunice, did you want to come back on that, or you? Okay, thank you. Thank you, Nilou. I just wonder then if I guess I had a point on the back of Nilou's, but if all our funding is going to clinical academics, then how do we continue to invest in the other levels of the workforce to be able to continue with the research?
Yeah, I don't believe there should be a different funding, Jill. I think it should be embedded within our clinical practice. Despite this debate, I really believe that it should be one pot, encouraging both.
Thank you for coming across to my side of the argument. At least I'm going to take that as a win for me.
You've won.
I've persuaded you to believe that it needs to be equal investment rather than prioritising clinical academics over other groups. At least that's how I'm taking your.
Yeah. And you're actually muted, Nilou. So we'll move on to another question just before we get to it's good to have a heated debate for sure, and to have our thinking challenged. Neil, is there another question for us to move forward?
Sure. We have an NMAP postdoc forum with the mutual objectives to support individuals and to think about how the postdoc community can support the organisation, but attendance and engagement is low. Does this suggest that the clinical academics themselves don't see the value of their role in the NHS?
I'm going to pose that question to Nilou first to take that. I think it's a very interesting and challenging question.
I have to say, I am challenged at times because clinical work is very demanding. And no, I don't think that is because I don't see the value. That's not the case. I joined the trust that I work in at the moment just over a year ago. And all my effort was to engage my department into continuous professional development. I'm constantly looking into little research projects, finding, pots of money here and there around the trust to engage pharmacists that I know they're going to do well in research, and they actually showed interest. But the process slows me down. The self or limiting step that slows me down is that heavy clinical work that I have to attend to, because at the other end of it, there are people who waited for months to see someone like me. Can't let that go. So yes, it's a slowdown and it's a struggle, not because I don't see the value, because I see the value in what I do as well as the research. So, but it slows me down. I agree with you. It's a struggle. You're muted, Jill.
Thank you, Nilou. Sorry. Eunice, did you have comments on that question?
Not so much for the debate, but just as a person who could be argued is heading towards this role. I really struggle to know why some people do not attend. It seems to me to be such a valuable forum to bring together people. And I just wish that within the CNS roles, there was a similar forum that would enable the engagement of the like minds, people who can spur each other on, who can bring in practice that is different but sheds light on their own areas. So to me, I don't know whether it suggests that they don't value their role in the NHS. I really don't understand it, but I do think we miss this kind of forum for other groups where it could benefit their research engagement.
Yeah, I'll just come in and make a comment on this as well. I don't think it's necessarily the fact that clinical academics or those pursuing kind of research postdoctorally in the NHS devalue what they bring. I'm not sure that they are sometimes valued by those around them, and that can then have meaning that disempowering to those individuals. But I think the other piece to this is just capacity to attend sometimes, and just getting being able to ring fence the time to be able to do that when you're also juggling the demands of clinical practice, team management, you know, in the more senior roles perhaps as well. So yeah, I think it's a real challenge in terms of being able to carve out the time and scope to do that, but not the fact that people don't value the opportunity to do so. Okay, I think we're coming, Neil, towards our time to think about the rerunning the poll.
Yeah,
May
we
I
are.
add just one small point?
Oh, sorry.
Could I add just one small point? I just feel that, like you said, sometimes research and you trying to actually conduct research within your clinical practice is not viewed by others as something that you do for the practice itself. I often found that it was viewed as your personal growth, or you know, that in fact actually whatever you discover about that population, it feeds back into bettering the clinical practice. And you know, in just echoing what you've just said, sometimes it's not viewed as such, which is sad.
Yeah, thank you, Nilou. I also just wanted to share Jane's comment in the chat as well, that research is often taught badly, can be dry, and doesn't spark the interest, especially at the beginning of healthcare staff, and that could be a problem. So maybe we do need inspiring clinical academics or clinical knowledgeable staff to be able to share their views and their experience and spark that excitement in others. So I'm just going to go to Nilou and Eunice individually just for their closing remarks to try and sway you just before we move into the final poll. So I'm going to go to Nilou first, who was presenting the case for the motion of prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice. Nilou, a couple of minutes just for some closing remarks to persuade your audience.
You're just on mute there, Nilou.
Thank you. Yes, certainly, I believe so, wholeheartedly, because I think it directly affects patient care. Better clinicians, more informed clinicians provide simply better care, and that's the bottom line.
Very succinct. Thank you very much, Nilou, for being tight on that. And Eunice, so to put forward the against, so your statement would be that it would not, prioritising clinical academic career development within healthcare systems wouldn't actually enhance patient care and strengthen evidence-based practice. So Eunice, your closing remarks for us, please.
Okay, Neil, would you mind putting up the final slide? Just so that people have a visual cue as well. My premise is that prioritising clinical academic role development would create losers in those who don't have the same advantages. The funding that would be diverted from other groups towards the prioritisation of clinical academics would mean that other groups do not have the funding that they need to grow and develop their roles, and they have good reason. We have evidence for particularly clinical nurse specialist roles, specialist practitioner roles. In lymphedema, they're one and the same. We don't differentiate between a physio who's a lymphedema practitioner and a nurse. And their role in terms of improving patient care using knowledge that they gain from their reading and from their involvement in collaboration with other specialists. My concern is that we would lose opportunities for these groups, and it would be to the detriment of our patient groups. Thank you.
Thank you very much, Eunice. So now if we have the poll back up, thank you very much, Neil. So closing poll, voting yes or for or against the motion, prioritising clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice. If you could vote now, that would be great, and then we'll share the results with you.
Okay, so we have the final poll results in. So for our opening poll, prioritizing clinical academic career development within healthcare systems would enhance patient care and strengthen evidence-based practice. Our opening poll, we had 100% for. In our closing poll, we had 83% for and 17% against. So there was a sway.
Congratulations, Eunice. I really think you've put forward a persuasive case there. I mean, I appreciate it's still in the slants of towards the for the motion, but I think a very, very persuasive argument, if you like, for want of a better description, in the case for against the motion. So I really take my hat off to you, Eunice. Well done. Great poll, and thank you very much to everybody for participating today, and for your comments, your questions in the chat, and making this a very lively and engaging debate for everybody involved. I'm going to hand back now to Ben for some closing remarks and to finish up today.
Thank you very much, Jill, and thank you very much for your expert moderation and sharing. Yes. Nilou and Eunice, thank you for those cogent arguments. I thought you both presented the case really well. And don't forget, there's no winners and losers in a debate. The people will decide. And Neil, thanks to you as well for your assistance. As always, it's great to have you around. And I always know that when you're around, everything will go really smoothly. So thank you very much for that. And then thank you everyone for participating. I hope you enjoyed it. I thought it was a lively debate. I wasn't quite sure what was going to happen in the end of it, but there you go. And for all your questions and comments. Fortunately, our last debate is going to be held in October the 31st, but it will be the same time at 12:30. It would be lovely if you could all join us. And I hope to see you there. In the meantime, enjoy the rest of the day and have a lovely weekend and look after yourselves, because I hear the temperatures are going to soar. So have a good weekend, everyone. Thanks for joining. Bye-bye.